I think we want.
Let's armed forces for many, many years, and she was one of the first lady doctor to be posted at the highest medical facility of India, Leh. And she has, I mean, enormous experience, and she'll be talking about managing the failing BLEBs. Dr. Sagarika.
Thank you, Dr. Parul. Practically a large numbers of aspects have been covered up and talked about. So what is it that we mean by an ideal functioning BLEB? When we see a BLEB which is low-lying, it has got very less vascularity, cystic changes are present, the intraocular pressure is in the low teens, let's say. It's a well-formed anterior chamber, it's got a tight conjunctival suture. All that indicates that it is a very good functioning BLEB. Anything which deviates from this, we know that's probably not functioning. But suppose we have a non-functioning or a failing BLEB, we have to recognize what is the cause of failure, identify that cause, and then deal with the intraocular pressure, and we have to try and restore the function. So you can, best is actually if you can do a good gonioscopy. I know this has never been stressed upon, but I feel a very good gonioscopy post-operatively, you can identify the sclerostomy, whether it is blocked or not blocked. Now, suppose it's a BLEB leak. I'm not going to talk about it. It's been already dealt with many times. Many of the doctors have dealt with it. Now, suppose you have an early post-operative, in the early post-operative period, you've got a flat BLEB. Pressure is very high. You've got a deep anterior chamber. Do a gonioscopy, rule out blockage at the sclerostomy site. If, let's say, the sclerostomy is maybe blocked, it may not be blocked. There may be blood clot over there. There may be fibrin over there. Just do gentle massage. You have to teach the patient or relatives how to do the massage. Increase the steroids. If you've got a vitreous blockage, do an Nd:YAG laser to break the blockage. You must try to do repeated massages. Let's say, okay, you've done the massages, that's been unsuccessful. Try to remove the releasable suture or do an argon laser suturolysis of the fixed scleral flap sutures which are present. This has already been discussed by many of the doctors out here. Approximately 10 days post-operatively, it is more or less safe. If it is still high, the pressure, then go ahead and do needling. I'm going to talk a little about how to do digital pressure. A lot of us do it from the lower lid. That's also fine. You can also do it by the upper lid. And this upper lid, you can use your finger. You can use a blunt-tipped instrument also. You can also use an impression by means like, for example, your Johnson's bud, has been described by Carlo Travoso. You just press over there and you can comfortably do it. What is very important is you must remember that you can develop corneal abrasions if you're not carefully doing it. You can have hypotony, flat anterior chamber. You can have hyphema, as stressed upon by Parul. You can have iris incarceration because of the ungentleness with which you did it. You can have choroidal effusion and hemorrhage. So ocular massage is suitable for those patients who are physically capable. Now, let's say, for example, you're telling a patient who's got Parkinson's, do a massage. You can't expect him to do it at all. So who is physically capable of doing it, and when you have done an ocular massage, that patient has got a beneficial effect, then that person will probably benefit from it. You can also release these releasable sutures. We must know how to release the sutures and when to release. A little bit has been talked about it, but remember that suturolysis and all this depends upon the amount of mitomycin you have put, how long you've put the mitomycin, how tight you have put the sutures, and also remember it is the patient's tendency to fibrosis. A lot of patients fibrose very fast. It's very difficult. I'm not going to go into the methods, but what I would like to tell you is you can use both the diode laser as well as the argon laser. And if you do, let's say, suturolysis before the third postoperative week, there is a slight risk of hypotony. We must not forget that. There are certain limitations also of suturolysis, like suppose you've got a thick overlying Tenon's capsule, you've got postoperative inflammation, subconjunctival hemorrhage, then they're not really likely to survive. Now, you can also remove the releasable sutures, which can very comfortably be done on the slit lamp itself. But please be careful. Take a sterile needle. In these days of lawsuits, please show the patient that, look, you are taking out a sterile needle, you're bending it in front of them, or you're not bending it, you don't need to do that also. But please show the patient, please put antibiotic drop before and after, and only put 1 drop of paracaine, and you can comfortably do it. Don't put 2 or 3 drops of paracaine, you're going to ruin the cornea. You can also use adjustable sutures. I don't have experience in it, but yes, Pencor definitely does it. And as per him, he uses his own suture tying forceps, and it is very easy. So you can also use anti-proliferative therapy. Now in RP center, I think Parul and everyone will bear with me, we used to take mitomycin and 0.2 milligram per ml, and on the post-operative, take the patient into the OPD, and then on the BLEB, put this in the form of sponges, and then after that, keep it for about say 2 minutes or so, remove and wash it thoroughly. Do it for 3 consecutive days. This also would help in the revival of the BLEB. Next is that if you've got an encysted BLEB, try to give aqueous suppressants. And you can also do BLEB needling. There has been a prospective study in which they have found that it's better to do medical therapy using aqueous suppressants over needling of the BLEB in management of encysted BLEBs. This is of one child who was a 4-year-old who landed up with this. Now let's say all this fails. You've tried everything. Everything has failed. Then you go as to what has described by Pencor as BLEB needling. And again, do a sclerostomy to see whether your sclerostomy site is opened or not. You can give mitomycin or any of the anti-proliferative agents away from the wound earlier, and after that, go ahead and do it. And let's see, you can do this in the OPD itself, on the slit lamp, and it's very easy to do it. But important thing is take pure aseptic measures, and then after that, see, you can just comfortably, I'm doing it on the slit lamp, and you can break the adhesions over there and this can result in a beautiful BLEB. Now this is when we are using a trocar. This is in the OT, and we're using a trocar over here, and we can in fact remove this thing of sorry, it's not moving. I'll go ahead. And don't forget that even BLEB needling can result in a lot of complications of hypotony, early complications, late complications. Most important complication is blebitis and endophthalmitis. Don't forget about that. And even this simple procedure can land you up with malignant glaucoma, which Dr. Manavdeep has talked about. Now, this is another thing which has come up, and this is by Davinder Grover and Feldman. And we have used this procedure in which first, when you're finding that your BLEB has failed, it may be even 10 years after surgery, and so you give mitomycin injection away from the wound and approximately just 0.5 ml into the subconjunctival space, and a week or so later, then you do this BLEB needling. But this is an ab interno BLEB needling where you anesthetize the eye, and then I'll just show you a small video on this. And see, after that, so you first put your gonioprism, you have a look, where's your sclerostomy site? You can see the sclerostomy site over there. Try to mark it. I didn't have a proper good gonioprism, so therefore I used this one only. After that, fill your anterior chamber with lots of viscoelastic, preferably a thick like Helon or let's say Helon GV, and then use the Feldman spatula and then go into the BLEB. This is the ab interno procedure, and try to break those adhesions. See, you can see I have gone into the BLEB and I'm breaking all those adhesions. You can come back, have a look at it again, and again proceed forwards, and then goes right through the sclerostomy, and you can see it so beautifully, it then breaks off. Now, we really couldn't make out, are we really being able to do revision? Is something really happening? So my operating room assistant told me, ma'am, why don't we put a little bit of dye? So I put dye, and there, lo and behold, we find that, the BLEB, the dye has come out, thereby showing us that definitely this is working. So this is a very, very good method, and I will tell you about just one case, and that is, this is a gentleman who was 76 years old. I operated did a phaco trap for him in the Armed Forces Medical College in 2011, and he was a single-eyed patient. This was his only eye, and his PL, the left eye was PL negative, and then he kept on getting treatment done in Leh itself on the follow-up with Travacom till March of 22. So 2011, 2022, 10 years later, his pressures rose up. That is up to 34. We gave him all the treatment that was possible. Ultimately, he came down to Delhi, in which I did a subconjunctival mitomycin, the same procedure which I've told you. And then after that, I did the BLEB needling. The video that you've seen is of this gentleman. And after that, we found that, see, therefore, he was a PEX glaucoma, and you find that this was how the BLEB was before, and he had advanced glaucoma in one eye. I want to show you how the IOP changes. See, on 12/3, first the IOP was 12. It went down to 2. This is ciliary body shock. He was mildly myopic. This has been stressed upon. A person who is mildly myopic, please don't forget that you can land up with ciliary body shock. Now, this patient was just on timolol. It has risen up to 14, and the patient is now on 2 drugs. Even if we can save this eye, this one-eyed patient with just 2 drops, we have done a great job. Thank you so much.
And thank you, Dr. Sagarika. I think we have just time to take one question. I would like to ask the panel and Professor Das and Professor Manavdeep Singh that in cases, of failed trabeculectomy, what is your threshold? Till what time do we think that we can consider a needling, or when do you decide for a repeat trab?
Can I answer this question since you have asked me? You see, if a patient, it depends totally on the patient's optic nerve. If the patient is, for example, one-eyed, and the patient has got a very large glaucomatous optic neuropathy, my threshold is very low. By your attack, before that person goes blind, you can't afford to wait. Therefore, you can give him a little bit of good BLEB revision. Mind you, these BLEB revision, especially the ab externo ones, we all know they really don't work all that well. And sometimes they work very well. I've done so many of them, but sometimes they just fail because you can't see the edge of the wound. And as a result, you can't go in. Whereas if you do an ab interno one, I've shown you, it's there. It goes long. And so that if suppose we find that no, the patient is not going to be able to wait for that long, then go ahead and do a retrab. But mind you, a retrab in these cases also, it is fraught with complications. So you have to be very careful. Thank you.
So
I think with the needling, so do it within 1 month. If it is BLEB revision, wait for 2 or 3 months. But as Dr. Sagarika correctly said, that if the condition is very precarious, it is the advanced stage of glaucoma, very severe, I think early intervention